Okay.
So, everybody, and I agree, is nervous about giving anti-VEGF to a pregnant woman. The data doesn't support our concern, but I think we all would be hesitant to do that. So here are the options on the bottom. And I think we talked about laser. We talked about Ozurdex, which would be a good choice. One other option is observation. Patient 2060, that's not a good eye to observe. However, let me show you this. So remember the RESTORE trial. So the RESTORE trial was a phase 3 trial done outside the US that led to the approval of ranibizumab for DME outside the US. And so the RESTORE trial had a ranibizumab only arm, the top black, ranibizumab plus laser, which was the intermediate one, so laser actually compromised vision. And the bottom was laser, and then after 1 year, patients became eligible for ranibizumab. And after 3 years, that group caught up to the laser plus ranibizumab from the beginning. So we know that 2 years is waiting too long. The RIDE showed us 2 years waiting too long. 1 year probably works. You can probably play catch up. So in a pregnant woman that's 4 months pregnant, 5 months later she's going to go ahead and deliver. Waiting 5 months may not be a bad thing. So I don't know this is my first choice over something like Ozurdex, but I throw it out there as in the anti-VEGF era, it's not a bad option because it delays visual recovery, but it doesn't appear to delay the complete visual recovery. So here's a patient, 20/20 minus, OCT shows non-center involving DME. Is there a role for anti-VEGFs in eyes with severe non-proliferative diabetic retinopathy with good visual acuity? So there's no DME, severe non-proliferative. Do you inject anti-VEGF in these patients? So you're treating it for diabetic retinopathy. Anybody do this?
It's severe non-proliferative.
Yep, severe non-proliferative, but it's not good vision and not vision threatening yet.
Okay, in normal cases, I will do laser, panoretinal photocoagulation for severe.
Okay.
In our case, we know if we inject with anti-VEGF, the retinopathy will go back. So it would be logical to put anti-VEGF.
So it's certainly indicated, isn't it? I mean, ranibizumab is indicated for this, and aflibercept is now indicated for diabetic retinopathy as well with DME. So the drugs are indicated. The question is, do we use them? I don't know. They're expensive. It's a long series of injections. Personally, I don't go there, but the indications are there should we wish to pursue it.
At the moment, I will do laser.
Later. Okay. Yeah.
Because of the patients we have here that they don't come back too much, then we should do laser.
Yeah. I throw this one up here because I think we use the term DME all the time, but when I ask a group of people, what's the definition of DME? Everybody kind of looks blank. And nobody knows. And I had to look it up myself as to what the definition of DME is. It's a macular thickening, 2 disc areas, 2 disc diameters in size within 1 disc diameter of the fovea. So as opposed to SME, where of course it involves the fovea or immediately threatens.
Also the presence of hard
X in the fovea, exactly, with edema within 500 microns, yeah. So DME is that top definition. And of course now we're really dealing in the anti-VEGF era of center involving versus non-center involving DME as opposed to the SME era from before. So both of those drugs have been approved for the treatment of center involving DME and for diabetic retinopathy in eyes with DME. And in fact now ranibizumab is also approved for the treatment of diabetic retinopathy. So it's even a further expansion on their label. But does that mean we should treat them? To me, I don't know. I don't use them for that reason. I think we all agree it's probably not something we're looking for. Or if I were to use it, I'd probably use bevacizumab simply for the cost. I hate to take a patient down this pathway of a lot of cost when to prevent things down the road, but we don't necessarily know that we're going to get them.
And I see patients that they start to inject it and for any reason they stop it. And I don't know why, but my personal impression is that the neovascularization was harder to treat. So I do pump visualization, I have to do again, and I have to do again. So usually don't work in this way, but it's one or two cases, but give me that impression. So that's my personal opinion.
And so I don't know if you guys have seen that as well, but there was a series of patients from about almost 10 years ago with macular edema from vein occlusions. This was reported by Larry Daisy and his group from New York, where they treat the patients successfully, and then the patients got lost to follow-up, and they came back, and the edema was worse than when it started, and harder to treat. And so one of the theories is maybe that period of rest where they weren't getting injections, like the VEGF receptors were upregulated more than the beginning, or something like that. So biochemically, it made the eyes more VEGF sensitive than they had been initially. So it's a worry.
One of the things that I believe, there is few data about this, but I believe, is that the combination of anti-VEGF and laser can have higher rate of disappearance and neovascularization with fewer spots. Especially when sometimes you can give in whole periphery. I don't know, maybe it's like a threshold when you pass this and you give anti-VEGF, it's more worthwhile. I see some papers of that in one of the hospital. In the hospital I give my I do my fellow. That was the way to do it, and I see work very, very nice, the combination of both, but not only anti-VEGF.
Yeah, and I agree with you. I think that's probably the case, but I haven't seen the data either. The advantage to that is if you do your scatter laser more peripheral, and hope to get an anti-proliferative effect, you may have less problem with visual field at night blindness. And so that's the advantage, I think, of doing it your way. And it makes sense to do it that way.
Do patients compliance with visual field loss? We have been doing laser for 30 years. My patients came from 30 years ago, they are walking, they are reading, they are doing everything, and they are still okay. And I do a PRP with 1,000, 1,200 spots of 500. I don't have so many troubles with my wife. I do not do the tests. I know how, but they don't complain. I can see doctor, I cannot see in the night, I cannot drive. They are driving, they are reading, they are doing a normal life.
So I have a couple of patients, not one I've treated, but some that others have treated from years ago, that are very dense laser. And they come in and they're nearly legally blind because they've got visual fields like this. And they have problems with walking. So I don't know if that's the degree you're talking about, because you're talking about light treatment. These were very heavy treatment.
No, like a complete PRP with 1,200. 3 sessions of 400.
Yeah.
But with normal photocopies.
No, yeah.
Not that one that you can see retina.
Yeah.
Your patient, how do they complain? They complain, your patient.
Yeah, well, these patients say,
These patients, but they were not going by you, the laser.
Yeah, so I've not had that problem with me either.
Okay.
I don't treat that heavy, and I think the heavy treatment is the problem. So I think if you're going to treat them in this era of now that we have anti-VEGF working for proliferative retinopathy, if we're going to do laser, we need to be wary of preventing overtreatment, because we don't want to lose the vision that we know anti-VEGF preserves. So
meaning gray marks? Is that your
yeah, I'll go towards white, but not overlapping.
Okay, so
leaving some spot area in between, at least a disc area in between, and maybe do what George Blankenship described years and years ago, of sort of starting in the mid-periphery and treating out from there. Don't go up to the arcades in the initial treatment. Start more peripheral, at least one spot size of diameter apart, and so it's not over-treating and it's more peripheral.
300?
300
spots.
No.
Spot size.
Oh, spot size? Yeah, about 300. I mean, anywhere from 300 to 500.
Okay. Because the lens increases the size of it.
Exactly. So it depends on the lens you use. Exactly. And I'll usually use either a Mainster or pen fundus lens. And so I dial down the spot size to about half of 500, whatever it is on the arm.
But you're combining both therapies, or you are only doing anti-VEGF in.
I've not been. I either choose one or the other. So I
or you do laser, or you do anti-VEGF.
Whereas a lot of people I know will combine. They'll go ahead and they'll start with VEGF, and then once they have a VEGF injection or 2 in, then they'll do laser, hoping to get a long-term effect.
You start with anti-VEGF because you have macular edema also. So you treat the macular edema first, and then do the pan photo, the PRP, to treat the rest. So you combine.
And it's perfectly reasonable. Yep. And when it's DME, then it's necessary.
Yeah.
Then you don't want to rely on laser monotherapy. And of course, from Horizon Ride, we know that 2-step improvements in DME were pretty significant. So hence, the advantage to treatment with anti-VEGF for therapy. But again, do we want to treat just patients with DR or DR plus DME? I think that's an individual decision at this point. So major points from this: the anti-VEGFs are obviously first-line therapy. Each drug binds all isoforms of VEGF-A. Each drug works generally very well. Aflibercept may have an advantage in those eyes of 20/50 or worse with DME. All the drugs equally effective for 20/40 or better, and quite frankly, I normally use bevacizumab. I go with the cost factor. And again, aggressive therapy done on a monthly basis is probably the way to go. So, complicated process.
Thank you.
We could talk all day on that. And thank you for your inputs. This was really great.
Thank you.